He is a distinguished professor of general surgery at King George's Medical University and is a leading light in thoracic surgery. Thank you, sir.
किसका पहला है? पैट्रिशिया ये कॉपी है ये ना वीडियो मिसाल और इस प्ले मत कॉपी हो गया कंप्लीट हो गया हाँ ये पेन ड्राइव ठीक प्ले मत करना ठीक अभी हो जाएगा वो बैठ जाए तब चलेगा हाँ हट गया हटा वो बोल लेंगे तब चलेगा ठीक नहीं ये रिकॉर्डेड लेक्चर चलेगा So recorded.
Recorded.
Very good morning to all the faculty members and our dear staff. The first oration is a recorded one, and this will be delivered by Dr. Patricia Newman, who is a pioneering surgeon and educator. She joined State University of New York in 1970 as their first female surgeon. Then she rose to become a full professor and then Lloyd as Rogers Professor of Surgery. She is specialist in endocrine breast surgery. She founded the Newman Breast and Endocrine Surgery Center. Dr. Newman's leadership includes presidencies of the American College of Surgeons, the Association of Women Surgeons, and the American Board of Surgery. Her numerous awards include the American College of Surgeons Distinguished Service Award and Lifetime Achievement. So it is just a summary of her achievement. Let's see what she wants to say for all of us.
Professor Sonkar, fellow surgeons and guests, Thank you for the privilege and honor of delivering Professor S.C. Mishra Oration at this, your annual Surgery Foundation Day at King Charles Medical University in Lucknow. I'm truly sorry that I am not able to meet with you in person, particularly since I'm sure the weather there is much better. It is currently 0 degrees Celsius and snowing here. Professor Mishra, when serving as the chair of your department for nearly 20 years, was a transformative leader who strove to bring the best talent to your university and the best care to your region. Therefore, I thought I would talk about a topic which would have been dear to him, assuring excellence. My favorite statement regarding excellence, although by an anonymous person, is excellence is never an accident. It is the result of high intention, sincere effort, intelligent direction, skillful execution, and a vision to see obstacles as opportunities. This statement captures the essence of excellence, which is that it is within our control and can be achieved. Today, I would like to speak about how we achieve excellence as surgeons. To achieve personal excellence, we must first look at what characteristics enable us to be the most effective person. Steve Covey captured these in his book, 7 Habits of Highly Effective People, published in 1989. He basically tells us not to wait for an invitation, but do what we see needs to be done. So, when you see that the residents need a new skills lab, you figure out how to accomplish that, even if it has not been mentioned as a priority. When you set the goal, then you develop a plan. I found it best to let in the department head on my thoughts, but not too early. You identify and do the most important things first. You need to understand the problem and be able to articulate that to those you need to help you, and look for what they can best contribute. You will be more successful if you create a program which assures all benefit. That is a win-win situation. It never hurts to look good. You must be decisive and persistent. Not all things happen quickly. As a matter of fact, most require patience. I found never asking for permission before I got fairly far along worked for me, as by then you have usually gotten some significant buy-in and support. Some things which I was involved in that were things like the formation of the Association for Surgical Education, the Association of Women Surgeons, the passing of the Mammographic Quality Assurance Act, the passing of the World Health Organization Surgical Care Act, and the founding of our local breast cancer center, to mention just a few. None were easy, and all took time and collaboration with many other like-minded people. I found working on these projects gave me great pleasure and pride, as you will when you work with your own community and university. It is also critically important for all surgeons not only to be competent, but for many to excel in surgical care. A recent study published by the Canadian Journal of Surgery has shown that surgeons, to be regarded as excellent, need to be excellent diagnosticians, have sound judgment, and be technically excellent. They need to be able to maintain focus on their goals and have a positive attitude. Determination and persistence are crucial. They never give up. They often drive us a bit crazy with their persistence. They never seem to rest on their laurels, but constantly seek ways to improve. They are the people who you can count on to get a project done. These surgeons often are chosen to be leaders. Being an excellent leader is tough. Remember that when you do not get what you want from your chair. They may be having a hard time. Helping the leader do their job and being supportive really buys you brownie points and often helps you get what you want in the future. Making someone else look good and helping them achieve their goals, I found to be one of the most rewarding things I do. It surprised me to find that beneficence always seems to find a way to come back to benefit you as well. Perhaps the hardest part of leadership is to consistently exhibit moral courage. Moral courage is being willing to stand up for what you believe to be right, regardless of the personal consequences. Gandhi is certainly a great example. One of my personal heroes, Dr. Claude Organ, would always ask when discussing a challenging issue is,
Are we doing the right thing? I often ask myself that when making a decision. To me, it is also always followed by for the patient, even though it might be tougher for me. Perhaps for me, the hardest aspects of leadership is that some people really don't like you and can even outspokenly say bad things about you or retaliate in ways that scare you. I have actually been surrounded by police at a meeting where activists were threatening us. You need to be willing to have people disagree with you and not like you. As another one of my heroes, Eleanor Roosevelt, the only publicly visible woman of note in America when I was growing up, would say, "Do what you feel in your heart is right, for you will be criticized anyway." I would add to that, if possible, support your position with data and listen to the opposition. You often learn things you did not know, which may alter your opinion. It is acceptable to change your mind for good reason, but don't waffle. When I was medical director, I found that when there was a problem, you not only needed to get both sides of the argument, but also see if you could find a neutral observer to get the real story. Incredible what the differences often were. You sometimes would think one was describing a bird, the next a dog, and the third a camel. The truth usually would be somewhere between. To withstand criticism and be effective, yet not destroy yourself, you need to develop moral courage. Important to your moral courage is to develop respect from others, which is best done by being honest. You need to be able to be honest with others by having tough discussions when things are not right. I have found the advice in The 1 Minute Manager, written by Blanchard and Johnson and published in 2003, a very short book, gives the wisest advice on how to have difficult conversations. Basically, it says you should give the advice in a timely fashion, not so far after the event that they don't even know what you're talking about. Not in a public setting, so not in the hallway or during conference, but in a private setting. State the issues specifically, not you are a stupid, clumsy resident, but rather, when you were dissecting the portal triad, you clearly did not know the anatomy and did not dissect carefully. I might add at this point that as teachers, we are not often as good at giving feedback as we should be. I ultimately made it a habit to give feedback at the end of every case, both good and bad, as well as point out during the case ways things could be better. It's very important to use the time in the scrub area and the turnover time, et cetera, usefully. Never shout or be impatient. It makes the situation worse. When you identify a problem, make a recommendation, such as in the case of the portal dissection, go to the skills lab and then scrub with me on the next portal dissection so I can demonstrate to you better technique. Personally, my rule was also never to say anything about someone you had not already said to them. Don't gossip. There is an old saying that it is their tale to tell. It is important when striving for excellence to invest in yourself. As you can see, I read a lot of books. I often attend leadership workshops. One of the best I ever attended was a one-day program on how to deal with difficult people. It helped me not only in my leadership roles, but also in teaching residents and students, as well as in caring for patients. The most important thing I learned were first to figure out their personality type and what motivates them. Are they bullies? Do they like titles? And then use that to control the situation. Also, to never lose your temper. You always lose the game when you go ballistic. You not only lose others' respect, but there is a lot of data to show that people around you will often then not do what they know to be the right thing because they fear your wrath. Institutions are now ridding themselves of bullies, as no matter what their talent, they are a real liability. Errors, lawsuits, lost employees. Often you can best learn from others how to solve a problem. As my father would tell me, I am not sure you will survive always having to figure it out for yourself. You might guess I was pretty stubborn and quite a risk taker. An increasingly popular approach is to hire a coach who is not part of your circle and with whom you can discuss issues that concern you. or who can help you strategize an approach to a problem. Surrounding yourself with a diverse group of intelligent people is always helpful to become the best you can be. Never fear surrounding yourself by really talented people. Just by association, you will be thought to be terrific. Otherwise, why would they be your associates? I frequently find myself emulating heroes, and I am sure that you also have those people who you really wish to be like. The need for emotional stability is increasingly recognized as important in being excellent. When we are in the midst of crises, personal, health, financial, societal crises, and are troubled, we can never fully focus on what we are doing. Distraction can have terrible consequences, such as technical or diagnostic errors. When we recognize these issues in ourselves, we should seek help, or when others reach out to help them. I once had to lie down on the floor in the OR, so I did not pass out. I knew I did not feel well, but I had to do the case. Fortunately, a colleague took over. It could have been much worse, just as I was fortunate when I fell asleep driving and knocked down a tree and several street posts. I am a denier, as I am sure many of you are as well. Be sure you have at least one person who will tell you what you need to hear to get help. Having diverse interests and groups of colleagues is helpful to reduce and manage stress. As I was once told when I was having a bad time with a leader, seek gratification elsewhere. Be able to move away from the unpleasant situation to one that makes you feel good. Focusing my energy with people I liked and respected really helped me get through the wrath of my constant critic. As surgeons, we not only need to be excellent diagnosticians and clinical caregivers, but we need to be technically excellent. Paul Kalanathi, a neurosurgical resident dying of a brain tumor, said in his autobiography, "Technical excellence is a moral obligation." I had never thought of it that way, but certainly agree that technical competence is what we all agree is essential in any surgeon. Excellence is found in few, but now there are so many ways we can both teach and become technically excellent. Surgical skills labs have made a tremendous difference. As any gifted person will tell you, practice makes perfect. You can easily record your procedures, particularly when doing minimally invasive or robotic procedures. Analyzing tapes of your procedures, as well as the tapes of experts, can help you improve your technique. And that is true even as you advance in your career. Now you can find almost anything on YouTube. Imagine my surprise when my 5-year-old nephew was watching a hernia repair. He thought this hernia operation was just great. Some basic rules in becoming technically excellent are to avoid unnecessary moves and develop a routine approach to an operation. The latter also helps your assistants do a better job and become better themselves. I had one scrub nurse who prided herself on never having to have me ask for an instrument. As a resident, I was glued to my technical atlases and anatomy books. These new learning methods are so much better. You can watch experts no matter where they are. I tell students to learn to use their non-dominant hand. As to be any good, you need to be ambidextrous. It gives people a good excuse to play video games or texts. New technologies such as 3D imaging can allow you to anticipate challenging parts of operations and pre-plan an approach, or perhaps engage another surgeon specialist who has more experience in that particular problem. For example, when doing a Whipple, when you know that the vascularity is involved, you might wish to have a vascular surgeon or transplant surgeon who's used to making those anatomic anastomoses available. One of my last cases, was an unusual tumor of the thyroid area, actually a non-chromaffin paraganglionoma that invaded the larynx locally. With me doing the thyroidectomy and my ENT colleague doing laryngectomy, we were able to more quickly and easily, and I would say better, resect the tumor. You sometimes need to give up your ego and get help. Minimally invasive and robotic surgery may help you gain access to regions which were difficult to access with standard open techniques. Be sure that if that is the case and you are not a minimally invasive or robotic surgeon, you refer the case to one who is. I had to give up one of my favorite operations, adrenalectomy, when it was clear that minimally invasive surgery was better, and I knew I would not do enough to make me excellent. Adequate follow-up of your patients to assure you know your own complication rates is critically important. From the beginning, I kept my own records. Incidentally, if you ever get to Yale University's Cushing Library, you will be amazed at the meticulous records he kept way back then. The ACS has a very helpful tool called the Surgeon-Specific Registry, which not only helps you know your data and track it, but through the NISQIP program allows you to compare yourself to other surgeons, making it easy to keep your data and work to constantly improve. All ACS fellows have access. You may have your own tool or could easily develop one, or even just keep your own records, as I did. One of the things not always included in postoperative assessment is the skin incision, which is actually the only thing the patient really sees of your work. Be sure it is cosmetically the best it can be without compromising your surgical access. My staff used to call some incisions we saw the Frankenstein incisions. You thought that whoever created them was trying to assassinate the patient rather than operate on them. We can learn a lot from our plastic surgery colleagues in this area. They know how to make incisions look perfect and heal perfectly. Certainly, oncoplastic breast surgery has taught us that we can improve cosmesis without compromising care. That old adage that the wound heals side to side, not end to end, does not impress the patient who sees this gigantic incision. I also found as operations became technically easier, my incisions seemed to automatically get smaller. For my neck incisions, I found being careful to place them in an anatomic line when the skin was relaxed gave me much better outcomes. As university-based surgeons, part of our reputation for excellence, and which is expected of each of us, is academic productivity. As part of the Canadian Study on Surgeons' Excellence, they assessed the academic high performers and to a great extent documented what all of us in academia know. Surgeons who regularly do great research, receive peer-reviewed grant funding, and publish regularly are not the norm in university departments, but they are critically important to the future of surgery and should be nurtured and supported. In their study, only 36 of 379 surgeons were responsible for 50% of the publications. A great part of that was due to the surgeon's own personal drive, creativity, and education. Having an advanced degree made a difference. I urged all of our residents doing research to try and get an advanced degree and even maybe add on an MBA or education master's. The department and institutional policies made a huge difference in academic productivity. So we need to be sure that the leadership of the department and institution are committed to providing the time and resources to facilitate academic activities. Then when we get these opportunities, we need to produce. I found I can only do best what I love. Basic research was not it. I tried for 10 years, had peer-reviewed research funding, but did not enjoy it and felt I was not contributing anything meaningful. So I gave the money back, closed my lab, and pursued surgical education as my academic activity. Much happier. We, as the research-talented surgeons' colleagues, must not only recognize their special talent, but actively support it. Don't expect the same clinical care commitment and committee assignments if you want academic productivity. I always supported any surgeon who wanted to do research, but then demanded productivity. I also always warned our residents to look at their researchers' productivity when deciding on a mentor for themselves. In order to assure excellence, we must constantly look forward. We must be aware of change, or we will rapidly fall behind and become not only no longer excellent, but obsolete. Change also offers many opportunities for research and for establishing oneself as an expert in an emerging field. I find the opportunities that are currently emerging, such as reducing waste in the hospital and improving the OR environment, exciting. Some work in recycling pre-incision waste, introducing reusable gowns made of more suitable materials are a couple of areas I find of particular interest. Surgeon-specific or even agreed-upon standard instrument sets can be very cost savings. Team training has been proven to increase safety, improve satisfaction. You can be a leader in your center, even though you don't do basic research. We have recently begun using drones to move medications, some supplies and specimens from one site to another to improve availability and decrease costs. Particularly to and from remote sites in traffic-dense areas, this has been very successful. Telesurgery is coming, and early telesurgery consultation is here. Lead or be led. The rapid development of artificial intelligence is being applied to medicine, particularly in communication with patients. I can see applications to education and training. You can become the expert in a new area much more easily than competing for that position in well-established fields. Computerization has made big data manageable, giving us a new way to look at some problems. Each population and each socioeconomic area has different needs. So even studying methods found beneficial in some areas looking at it in yours is important. We know that extrapolating results from one group to a vastly different group is inappropriate. Standard screening and preventive programs developed in other populations may not be best in your population. Research is needed in so many areas, not only in the pathophysiology and treatment of disease, that most academic surgeons will find a niche, even when busy clinicians. So keep this in mind as you look to advance your career. Look for unique opportunities. I understand at King George University, you have a unique opportunity to work in conjunction with the engineering school SIBSHINE program to explore new areas of research. Contributing to progress is a way to separate one from the ordinary and make one excellent. In closing, I want to remind you that only surgeons can assure excellent surgical care. We always have and always will. Be part of that team. Thank you for allowing me to participate in your great meeting and bestowing upon me the great honor of presenting the Professor S.C. Mishra Oration.
Thank you, sir. Next in line, we have Professor P.C. Dubey Oration. And for this, I request Professor Suren Kumar sir to kindly be seated for our next session, and I request Professor Sandeep Kumar sir to kindly join Professor Suren sir. Sandeep sir is a former professor of surgery at King George's Medical University and founder director of AIIMS Bhopal. Sir did FRCS from the Royal College of Surgeons of Edinburgh and PhD from University of Cardiff, Wales, and second master degree in clinical epidemiology from Newcastle, Australia. Sir has extensive experience in surgical oncology and breast disease. We welcome you, sir.
Let me first congratulate everybody for the 73rd, is it? 113th Foundation Day of the department, to which I also have the privilege to belong to. And without much ado, let me invite our next speaker for the Foundation Day. And this lecture is in fond memory of Professor P.C. Dubey, my teacher, my mentor in a way, and when I joined as lecturer, I joined his unit for a few years, so I was there with him for about a good decade. So we have, gentlemen, ladies, friends, students, a distinguished AFMC Armed Forces Medical College alumnus, Lieutenant General Pankaj Rao. Please step onto the podium. I know him from my Indian Journal of Surgery days. He was one of the resource person for gastrointestinal hepatobiliary surgery in the Indian Journal of Surgery. I had a couple of interactions with him while he was the commandant and the chief of the command hospital, Lucknow. He's a GI and a liver transplant surgeon. He headed the team at the Army R&R Hospital, which you may know is a research and referral hospital in New Delhi, which now has become a teaching hospital also. A great researcher with over 60 publications. He's received innumerable awards, and he's currently the Chief of Army Staff, including the Chief of Army Staff Commendation Award. And currently, he's serving at AFMC, Lieutenant General Rao, as the principal there. He's the commandant of the Armed Forces Medical College. So, ladies and gentlemen, here is Lieutenant General Pankaj Rao, who would be talking to us on which subject, sir? A very important subject. I think this subject, once I only put it as an examination question, but if I am to ask to frame a question for MS surgery examination in an essay type, I would frame this question. So please take it seriously. It's extremely important. It is getting even more important in the AI era. That is ethics of organ transplantation. You know, recently one of very senior surgeon from Apollo Hospital in Delhi was jailed for some kidney transplantation issues. I know a couple of people who live in my neighborhood have been to Sri Lanka recently, have had their kidney transplantation done. And in Sri Lanka, it is not banned at all if you purchase the gurda of another person. And you can probably nowadays go to Bangladesh and buy gurda and get your kidney transplantation. I recently had my 30-year-old cook who's been in my house and a backbone of our kitchen. His son, who many of you have seen, I could not diagnose, had a posterior urethral valve, has a vesico-ureteric reflux, developed renal failure, 15-year-old lad, and only a week ago, his mother gave his kidney and had a kidney transplantation done at a private hospital in Lucknow. So it's a very, very important subject. So please pay attention and ask. We'll happy to answer a few questions, although it's an oration. Yes. Over to you, General Rao.
Thank you so much, Chairperson Sir, for the kind word of introduction and greetings from the Armed Forces Medical College for the Foundation Day celebrations of the Department of Surgery, KGMU. And I am thankful to Professor Sonkar for inviting me to deliver this oration of Dr. P.C. Dubey. When I was a teenager, I used to be very fond of reading thrillers, and this is one book that I read, the medical thriller Coma, which became very famous. And in it talked about that day will come when we'll be able to transplant any organ in the body, but it has to come with great bit of price attached to it. I never realized then that I would one day be involved in organ transplantation, and the price I would be paying is understanding the ethical dilemmas of organ transplantation. If you see, ethics is generally how a human being behaves in a particular circumstance, whether it's perceived as a good behavior, morally correct, or morally wrong. And as far as medical ethics are concerned, it rests on these 4 pillars. These are the principles of medical ethics, where the first principle is not to do any harm to our patients, respect their privacy, autonomy, and their decision, be fair as far as possible, and to do good. But as you can see, there'll always be a conflict. Even in these 4 principles that we have, there will always be a conflict, each one conflicting with the other. So which one takes the precedence? Which one takes, it's all a gray area, a complex area, and that's what intrudes everybody's mind. So why ethics for a transplant surgeon? I am a transplant surgeon. I was a hardcore clinician. I am not a bioethist. That why should I be dealing about ethics in transplantation? And if you see transplantation as such, it's grown by leaps and bounds. We are doing so much good to the humanity, so much good to our patients. And for a donor, it is such a great act of selflessness, be it a cadaveric donor or a living donor. So why should there be any problems at all? But when I started understanding, when I started working in it, when I grew a little more senior, I found that this is the superficial thing, and there are lots and lots of controversies, and I myself faced lots and lots of ethical dilemmas. And so I'm not a bioethist, so I'm be talking more about my experience, what I went through. Actually, each aspect of organ transplantation, who is supposed to give organ to whom, is a dilemma. Who should be receiving it, from whom, is a dilemma. Ethics are involved. And then gradually, as one gets senior, I was thrown into administration. And in administration, I realized that whatever ethical problems I faced as a transplant surgeon, the similar problems are there in the entire healthcare setup. Only in the transplant setup, they get magnified a little. And possibly we can take lessons from that, learn lessons, and apply it to the entire healthcare system. So probably we may be able to frame better rules and regulations. And secondly, as Sir rightly brought out, for each one of you, the residents, young faculty, junior faculty, everybody, ethics and ethical teaching is as important as clinical decision teaching. So what do we do when we are faced with an ethical dilemma? What do we do? What is supposed to be a good behavior, good ethical decision? We obviously have got to rely on the law, rules. The law generally takes care of all the issues, thank you, all the issues regarding how to come to a correct conclusion ethically. So obviously, the most important thing is to just stick to the law, and you will be right most of the times. But yes, law cannot tell us about everything. It is not all encompassing. There will be so many gray areas, so many areas where law doesn't specify each and everything. So there we have, like today I'm talking to you, there are some debates, some orations, some books that you can refer to, some symposiums, and of course, finally, what you actually do on ground is all this combined, you take a decision, and that's what we call as the common sense. Our Transplantation and Humans Act, the act came in 1994. They had a few lacunae, few sort of problems with the law. That got revised in 2011. Again now, now it's 2025. Another so many years have passed since the last amendment. People have found that there are a few issues with the 2011 Act also. There are a few lacunas, there are a few problems, and those need to be addressed now. So last year, under the NOTO, there was a national symposium on legal and ethical aspects of organ transplantation, and we hope that whatever points have come up during that symposium, we are going to take it forward to the government, and the rules and regulations and our act will be suitably amended. It is not that these things have started coming up now and we have started realizing that ethics is very important. Most of you must have heard of Dr. Joseph Murray. He was the first person who did kidney transplants. He is a Nobel laureate. He got Nobel Prize for doing transplant surgery, and he was a co-worker in identifying Imuran, that is azathioprine. So he got a Nobel Prize for that. Even he, when he started doing liver transplant, he said, my motives are very poor, but still I'm not very comfortable with this. It requires a lot of soul searching. And Dr. Stazel, of course, father of liver transplantation, even when he started doing liver transplantation in the humans, he first did it with dogs and then graduated onto the humans. Even he said that, yes, it requires some sort of good, fair, ethical setup, a framework on which we should work. Otherwise, there is going to be chaos. Then, of course, in '67, the first heart transplant took place, and a huge ethical debate that time erupted all over in the medical field as to should you be taking somebody else's beating heart and place it onto another human being. This, the picture that I have shown you, this is one of the first heart transplant that we did in our hospital, Army Hospital, about 15 years back. He survived for 15 years, but unfortunately during the second phase of the COVID, he succumbed to COVID. So that is in a just remembrance. So the problem of transplantation, the basic issue is that the demand and supply issue. The supply is far, far minuscule as compared to the demand. So whenever such a problem occurs, it's a human tendency to exploit it. So when you exploit it, there's going to be a problem. We are going to be taking routes which are not ethical. If you can just see this chart, this is an older chart, they're not the new figures, but the supply and demand ratio is almost 1 to 15, 1 to 20, or maybe more. So then, as a surgeon, I said, okay, there are problems, ethical issues are there, and I should just, how to go about it. So surgeons are generally typical, they bring out some sort of algorithm, break it down into smaller pieces. So I said, okay, let me just divide it into issues of the cadaveric donation, issues of the living donation. Then issues of the donor, issues of the recipient. Because otherwise, it's a very complex problem where patients are involved of various ages, different sex, different socioeconomic status, with children, without children, and then their immediate family members, their society, the healthcare system, and things like that. So this is how I have divided my thought process. So coming first to the cadaveric donors, death. Death itself is a big controversial issue. Then comes, of course, the other headings that I have given. So coming first to the, what is death? So you're taking an organ from somebody who is not living anymore. Traditionally, we know death as something where the heart stops. But the problem with when the heart stops is that the blood supply to the other organs also stop. So once that stops, all the organs starts failing. You cannot transplant an organ which is suboptimal or which is already not doing its function to to another human being, it's not going to function in him. So you got to take that organ during that stage when the organs are still working, and anything? So the organs are still working and functional. So that's the state when we call it as brain death. Now, all of you must have read in tabloids and some sort of social media and all that somebody was declared dead, and then after some time the doctors have declared him dead and all, he's got up and he's walked out of the hospital and all. So when you show a monitor to an individual, the BP is going on, he's producing urine, pulse is there, oxygen saturation is almost 90%, and you call a person, he's no more, he's dead, and we're going to take organs from him. At least in India, it becomes very, very difficult to convince somebody that this person is not living anymore. Of course, the seat of human existence is in his brain. That I'm absolutely convinced. Once your brain is not functional, there is technically or otherwise, he is not living any longer. But yes, what do you mean by brain death? Does it mean that his control over only his heart and the respiratory system is gone? Does it mean that the cerebrum, the thinking process is gone, or what? That's, again, a very complex issue, and if you keep thinking, there is no end to it. But yes, the 1968, there's a Harvard committee sat on it. They found a few tests, and if you perform these tests, and if these tests are positive, that means the person is not going to come, his brain is dead, his control over the other organs of the body are gone, and once you remove the ventilator or once you stop the inotropes or things like that, the body is going to eventually die. So that is what is called as brain death. And till today, millions and millions of people have been tested by this Harvard committee tests that have been devised, and not a single person has, if you call it alive or come back to life, once these tests were tested positive. So these tests are sacrosanct, almost 100% accurate. There's no question. Only time that they can fail is fallacies of a human being who is performing those tests. That is why we have two sets of different doctors performing it, so that even that fallacy is taken care of. Then the second issue that crops up is now we have started doing donation after cardiac death. That is, you wait in the ICU looking at that person for his heart to stop. Once his heart stops, you wait for 5 minutes and declare him dead, and then take his organs. So before the organs perish or they become, their function becomes less, you take them out. That also people find it a very odd thing. If you are able to revive those organs after 5 minutes, how can you say that the person is dead, and to declare him dead is a complex issue. It's something to think about. But yes, our laws are there with us, which tell you what is brain dead, how to do these tests, and who are supposed to be doing these tests. And if you stick to these rules and the law, I think we are safe and correct. Not just safe, we're correct. If somebody wants to read much more about donation after circulatory death, I think there is a good joint position paper in the Indian Journal of Critical Care. One can read. The problem with India, again, is that because of the reasons that I told you, people don't believe in the healthcare system, they don't believe in doctors, they don't believe in the institution, and our organ donation rates are abysmal, very, very, very poor. If you see I couldn't get the 2024 figures, but these are 2023 figures from the NOTO site, and it shows that out of a population of 140 or 150 plus crores, there were just about 1,099 organ donations from the cadavers, only about 1,100. And of course, the figures of 3,000 is you take kidney, you take heart, you take lung, you take, so 3 times as much. So the 3,000 actual surgeries happened because of 1,100 donations.
This excludes corneal donation.
Yes, sir, this excludes cornea, sir. This is only solid organ transplant. And if you see the state figures, these are the top 5 states where cadaveric donations have happened. So out of 1,100 that I showed you, 900 are by this. We have got 28 states and 8 union territories, just about 200 from rest of the other states. Armed forces is a shade better. I wouldn't call we are doing anything great dramatic. A little better, considering our subset of population that we are treating. In last about 15 years, we have had, our figures are maybe a little better than the national average. So, obviously, my aim over here is to spread awareness, tell you all, you're all the future, to go back, read about it, spread awareness, and we should be having more organ donations. One problem, the second problem is that about consent. Who can give consent? So when I am alive, I sign a form, that Form 7, which is there on the noto site, that I am willing to donate my organs in case I become brain dead. And I sign, they give me a card, I keep it in my wallet. Or sometimes it is written in your driving license that I am an organ donor, and in case something happens to me, I am willing to, my organ should be taken. But again, there's a gray area. More than not, what happens, even if the person has got that organ donation card, the next of kin of those people, they say, नहीं, हम तो नहीं देंगे, अभी तो ये जिंदा है, अभी तो हमको लग रहा है कि आप बेकार में ये कर रहे हैं, उसके पास कार्ड है तो क्या हुआ? So most of our organ donations fail there. There are some countries where the consent is taken as presumed consent, that unless he doesn't have to sign any form or things like that, he just, the government is fully entitled to take his organs. If there's a brain dead, they'll go and say that so-and-so is brain dead and we are going to retrieve the organs. But yes, in our country, I don't think that can happen, because then I don't know whether we are really fair and ethical people as such, and that may not work out in our country. So the Indian law says that we should go in for just a consent prior to his death. In armed forces, then another issue is that once you declare a person brain dead, बोला है नहीं आपका मरीज अभी is not there, and we'll be testing after another 6-8 hours by different set of doctors. And till then, you got to maintain him. He's on ventilator, he's on drugs, he's on inotropes, and each ventilator bed, you know how much it costs. Who's going to pay for that? The relative says, if you feel that the patient is not living, why should we pay for that? How ban kar do and just hand over the body to us. So all these are all gray areas. The government says that no payment to be taken from the recipient family. Then should the government be giving this money? Who will pay for this money? I'm serving in a government sector, so we have no such problem of money involved. So one way out, we thought, is to encourage this. We make that person's family hero in their society. We give them some sort of, we don't give them money or any gift sort of thing, but we generally give it in the social media, in the paper, newspaper, that so-and-so is donated. We go to their area where they are living and tell them that they have done such a great deed of donating. And this is how, in armed forces, we have been able to build up our donation rates, by making those persons hero in their society, by telling people that these people have done something exceptionally great, and they are the heroes, they should be emulated, they should be, they are the ones who one should follow. So this is what is the actual thing done by Tamil Nadu government, and that's how I think they are successful, because that is what is the Tamil Nadu model of what you would call spreading awareness about organ donation. And that is why Tamil Nadu has got more organ donors than elsewhere in the country. So as of today, the government says no payment for the funeral charges or anything to the donor family. Then at times, as I told you, donation after cardiac death, lots of these patients are on high inotropes. there may be a episode of cardiac arrest, we have revived and things like that. The organs are suboptimal, the enzymes are rising very high, patients are of elderly age. Should we be taking organs from them? Because we know fully well that it may function, may not function. So in that case, we generally tell the recipient, most of them are so desperate, they say, kuch bhi karo and kar do. If it works, it's good. If it doesn't, it's all right. But that's another gray area. As a society, I think what we should be doing is, the government has made rules of 2011 amendment that every hospital is now ethically mandated that they should be declaring people brain dead in their ICUs. It's a law. We do not follow it, but it's a law that we should be identifying brain dead, and the relatives should be counseled that so-and-so is brain dead and can be a donor. So that's what we can do. Of course, there are a number of people against it. They say that in our country, where we are not even able to give proper water and sanitation to our people, people are dying of diarrhea and dysentery, and you are spending crores and crores of rupees on transplantation. But I think that's an illogical sort of argument. Again, now coming from the donors to the recipients, allocation, who will get these organs? These organs are all government property, so it should be given correctly based on some sort of registry. So how do we make the registry? Somebody who is meeting those criteria that, yes, so-and-so person requires, based on the waiting list, as we have in our railways or wherever, first come, first serve basis. And secondly, on the urgency. If he's not going to live for long, then he jumps the queue, goes a little ahead, emergency quota, he gets it. So these are the two things we have in our country, but in other countries, it's much more complex. They have an algorithm based on age, the economic status, the probability of success, and things like that. But in our country, we kept it simple, time of waiting and the emergency. So NOTO is the nodal agency, which takes care of the registry and gives it as per their waiting list. Then other ethical issues also crop up in the mind, whether now there are a lot of influx from other countries. Should we be, if somebody requires, should we be giving our precious organs to them? What about second timers? Somebody who's been drinking, having merry on drugs and spoiled his organs, should we be giving organs to them? Somebody who is not financially very sound, should we be giving organs to them? Because he may not be able to take those complex immunosuppression drugs and come for regular follow-ups. I personally have seen one example when I was in All India Institute and doing my training there. We did a transplant on a 24-year-old engineer. He was working with the Punjab government. His salary that time was around 12 to 15,000 rupees, Punjab government. And he underwent a liver transplant, and the drugs and medication costed almost 25,000 per month for him. Initially, for a few months, the government started giving him because it was their responsibility to give him money. But when the bills kept on going to them, they said, your pay is 15,000 and you're taking 20,000 rupees, 25,000 rupees from us every month as medical expenses. This is not sustainable for us. And they stopped, or they started creating problems. So those are other issues. Should we be giving organs to them? That's another ethical issue. Then that is, of course, the cadaveric. Now coming to the living donors, another big ethical dilemmas follow. When you operate on a living donor, if somebody is giving a kidney, liver, part of the liver, or any other organ, there can be no surgery. You're all going to become surgeons or are already surgeons. There is no surgery without some amount of morbidity or mortality. There can be no surgery. Even if you do a simple sebaceous cyst, there's going to be some pain, some infection. It can get infected, things like that. So, and here you're taking a healthy organ from an adult who is in his productive age group. So you're going to cause some amount of morbidity. And in liver surgery, of course, we are taking 3/4 of the liver. Just 1/4 is left to the donor and 3/4 we take from the person. So there is mortality also. Though people don't advertise it much, but in this thing, I have seen mortality. And there have been papers there is a definite mortality, at least 0.003% means out of every 1,000 live donations of liver, one person dies or two people die actually. So a healthy man dying for just volunteering to give his organ is, I think, it's not acceptable at all. But when you see a small child like this, she was one of our Jawan's kid, extrahepatic biliary atresia, almost dying. And the mother was being prepared to give liver to this child. And post-surgery, the child became healthy, goes to school. Now I think these are older photos, so I think the child is now in 8th, 9th class. So when you see all this, you feel that these efforts are really worth it. Some amount of morbidity to the mother or whatever is acceptable. You're given some life to a beautiful kid who's got a whole life ahead of her. And we've also seen that people who have donated actually are mentally happier. They feel that they have done something in their life. And they don't regret having given the organ in spite of having a few little disabilities and problems. We also, in our own thing, we did a small little study on the outcomes of the donors, how the donors feel and what is their outcome. And we also found that most of them do well. So life-related organ should go on. There is no stoppage to that. The consent, who can give consent for a live donation? One always feels that there is some financial coercion or at least an emotional coercion, because you feel that society is obliged that यार अपने बूढ़े बाप को देख नहीं रहा है, दे नहीं रहा है लिवर, क्या कैसा आदमी है, कैसा लड़का है. So out of that emotional coercion, one tends to get into that sort of system and is compelled to give, or he feels that he should be giving. But no, human beings are not all that bad. They are all good people. Majority of us are good, altruistic people. And there's that Professor Lübeck of Germany. He was a professor of surgery, a kidney transplant surgeon. And he found that in his ward there was a teenager who required liver transplant, required a kidney transplant. And there was no donor upcoming for him. Nobody came. And this child was just withering away, dying for want of a donor. So one fine day, he himself volunteered and he gave his own kidney to this. Not related to him, nothing, he was just a ward patient of his. So people are there, good people are there, have faith in humanity, altruism is there. People do give out of altruistic motive also. Then as Sir brought out rightly, selling is one big issue. At one point of time, live-related kidney transplants was called as the Bombay procedure, because anybody and everybody could come to Mumbai, get their kidneys changed from all over the world and go back. It was called as the Mumbai procedure. And not now, this has been going on since the 80s. People from Middle East used to come, sheikhs used to come, people with a lot of wealth, money used to come, get kidney from somebody, go back. Like what is possibly happening in our neighbors now, neighboring countries now. In fact, in 2006, there was a tsunami in Tamil Nadu, Chennai, near Chennai. And they studied a village over there, next to that village where there was a tsunami. And every member of that village had donated the kidney. Every member. And that village itself was called as people started calling it Kidney Vakam, means a township of kidney donors. There are pros and cons of selling, but I think the cons are far, far more than the pros. Yes, people do have right over their own body, but I think the only people who are going to donate are the poor, marginalized people. They'll be exploited. So I think it's not a great idea of making it a commercial sort of venture and people given the right to sell their organs. In fact, that same paper about the tsunami people, they found that majority of the donors remained as poor before as after selling the kidney. Majority of them, in fact, after their big scar of the kidney, go back to work immediately, so they become poorer. They went into much more debt, and it was not a great idea of selling the kidney at all. So organ donation, selling is a big no, especially in our country. The recipients, of course, somebody is willing to give it to their own kith and kin, so the problems are much less. But yes, then if you buy an organ and all, that's not a correct thing. And finally, coming to the future, we are able to transplant any or every organ of the body now. Limb transplant, that is a non-essential or non-critical organs like transplant of the limbs and all is also known. Face transplant. And ethical issues can be as minuscule as having an organ which is a mismatch, like a white man getting a black man's limb or a leg. These are minor issues. To something like a face transplant where a personality or the identity of a person is his face, and you are completely changing his face and giving him a new face, whether that's ethical or not. And transplant from another animal is another debatable issue. Now, as everybody brought out, the future is all AI, future is all technology. So should we have an algorithm based on AI where it can decide on who will be getting the organs? That's another debatable issue. And of course, technology, as it becomes very expensive, maybe technology may benefit only the rich. That's another ethical issue. So to conclude, I think I'm pretty sure that organ transplantation is definitely much, much more than just saving lives. It's much more than knowledge. It's even much more than the truth. And for that, I think we got to find a solution as a humanity ourselves, and it's better not to depend on the divine intervention to guide us, but we should follow our own path. Thank you so very much.
Thank you, Pankaj Rao Sahab. Very important areas, very important points that you've touched upon. I will speak on 3 points because I've been given this chair, and I would not expect you to answer or get into debate because we can do that at the coffee break.
Yeah, absolutely.
Because this is not a time for question and answers, and we have to respect the next session and the next orator who has come all the way from Srinagar. Is that right, sir? You've come from Srinagar, our next orator. And the inaugural function is from 1 o'clock. Is Professor Sonkar here in the audience? No, he's not here. I'll raise my issues on 3 issues just to, with the objective of elaborating what you have said. One is ethical moral dilemma, which I faced once. Another eminent friend of mine, eminent pediatric surgeon friend of mine, Dr. Kuril, has left. But Dr. Saab is there, Dr. Tandon is here. We had this young girl with congenital biliary atresia who came to PGI Chandigarh, and the senior resident referred the patient from pediatric surgery to the hepatobiliary transplant surgery unit. Another senior resident, in the enthusiasm, not realizing the socio-economic background of the patient, of the poor father who was a mere rickshaw puller, was just a minion, who had brought this young girl whom he loved very much. And he showed her a slide like you did with a child who had a liver transplant done and was successfully playing, and didn't give him any idea of what was the post-transplant cost and what is the transplant cost. Those were the days when no philanthropy was helping liver transplant in children. I know about 2 organizations at the moment who are paying 15 lakhs of rupees, one of which is Anil Agrawal's Vedanta group, which I was also involved. So there was no philanthropy available, and he was told an expenditure of 15 lakhs of rupees. Now this father, he could have never afforded, but he could look at the other child who was leading a wonderful life, and this baby died. Now, here is an issue of ethical, moral dilemma. Ethics was that you should tell the father that there is a modality available in modern science whereby liver transplant, this child who was brought in a state of big jaundice and was literally not thriving, could have been a playing, chirpy child, and morality was that you should have not told that child. So there is an ethical, moral dilemma also in transplant, and we're facing it every day. The second thing about brain death, I won't comment much upon that. And third thing about is the post-transplant cost and post-transplant life, which I believe is a wonderful life. So I think it's a very, very important area that you have touched upon. And what I wanted to say also, that way back in 1972, I became a first-year medical student in Prayagraj. And my father returned from Belfast that year, 72. Many of you must not have been born at that time. And he came and he had worked in Belfast. He was in Northern Ireland. He had worked in Belfast, and he worked for 2 years as a registrar in the kidney transplant unit. Now, he described to me how the kidney transplant is as a bandobast in entire United Kingdom. Now, if you know, United Kingdom is 4 countries: Scotland, Edinburgh, Aberdeen, there at the top, Glasgow. England, the biggest one, with Midlands, London at the bottom, Cambridge, and Wales and Northern Ireland. Now, they had everybody who needed a kidney transplant, who was on dialysis, his blood group and HLA on the computer or on a central registry. There was no computer at that time. And the telephone used to work very well. Everybody who was a potential donor on the driving license, his HLA was matched, his blood group was known. It was done at that time. The moment there was a death of a potential donor, say up in north in Scotland, in Aberdeen, and there were recipients they would match on the central registry, which was somewhere in Midlands, in the Leeds area. They would match it, and they would ring up those hospitals that, look, this is the death, and we have a donor available. We have donor kidney available. Liver transplant was not done in those days. And would your recipient be ready? And they would identify 1 or 2 places. Meanwhile, there were 6 or 7 helicopters those days in 1972 standing in Belfast, in Cardiff, in Cambridge, in London, which would fly. The team would fly, go and harvest the kidney. There was no laparoscopic harvesting at that time. They would do an open harvesting. They would do the cold plegia, whatever it is done, perfusion, take those boxes, and the helicopter will fly it. Meanwhile, the liaison officer would liaison, and the recipient would come to the hospital and be prepared. So that is the kind of bandobast. Why the Indian figures are so dismal is because every transplant, what I say, I told my friend Arvinder Soin also, that this is being done on the behest of people like you. It has to be done it is not that India is a country of the Dadichi. People are ready to donate, and that kind of a syndrome that occurs when a person who has pledged, who has done a living will to donate, when he dies, the family doesn't want to donate, actually happens because the bandobast is very poor. And it is the Prime Minister of India who has to take up the call. And there is plenty of money in India sitting today. They want to spend in the health sector. They have to show it in the Millennium Development Goal and the Sustainable Development Goal that we have spent that money. They are opening medical colleges in every Jilla. They are opening AIIMS. After 22 AIIMS, they are going to open 5 or 6 more AIIMS. So there's enough money in the health sector. They've done Atmanirbhar, they've done this health insurance Mediclaim type of Ayushman Bharat. So there will be, the Prime Minister has to be convinced by all transplant surgeons to put up at least 20 helicopters in the country, drones in the country, make corridors in the country, educate the country on the level of, like you did Swachh Bharat and like you did Shauchalaya, and cadaveric transplantation, which is a minuscule in India, it has to be taken up by the politicians as a bandobast, because we have trained personnel like you, and that's what my submission is, and it can be taken over, it can be done in India. When Iran can do it better than us, when Sweden can do it at 60% of cadaveric transplantation with live donor transplantation, we can do it. I think we need the politicians' will right at the top.
Absolutely. I agree.
Thank you, sir. Now, next in line, we have Professor T.C. Goel guest lecture. And for this, I request Professor Apul Goel, sir, to kindly grace the dais. Apul, sir, is a professor and head of Department of Urology at King George's Medical University. His field of interest are endourology, reconstructive urology, and female urology. He has more than 400 publications and is a renowned surgeon and academician. I also request Professor Avnish Kumar, sir, to kindly join Apul Goel, sir. Avnish, sir, is a professor of surgery in King George Medical University. He is specialized in minimal access surgery, particularly gastrointestinal hernia and bariatric procedure. Thank you, sir.
A very good morning, and it's a matter of great pride for me because this guest lecture is named after my father. So I thank Professor Sonkar and the entire surgery department for initiating and continuing with this lecture. It's a matter of, it gives me immense happiness when I see the name of my father in the invitation brochure. So it gives me great pride to invite Dr. Iqbal Salim, who's a pioneer in laparoscopic surgery and is currently works in Srinagar, Kashmir. He completed his post-graduation in 1998 and received training at Apollo Hospital, New Delhi. He introduced laparoscopy to district and government hospitals, including MIPH for hemorrhoids. As a GMC Srinagar faculty member, he specializes in laparoscopic management of gastrointestinal cancers, benign stomach diseases, CBD stones, hernias, and hydrated liver cysts. So all the surgeries that my father was also very fond of performing. Although he used to do open surgery. He has been trained at All India Institute, Max, and Tata. He's a teacher, examiner, and active researcher with a large number of publications. He heads the general and minimal access surgery departments at SMHS Hospital, Srinagar. Dr. Iqbal Salim, over to you.
Thank you, Chairperson, and it's really great to be here. I come from another part of the country that is really cold this time, but the warmth that my people give me here, especially Professor Sonkar, it's really, really great. Okay, so is the mic working? Thank you, sir. Thank you for calling me here. And I'm really great, feeling great that Professor Opal is here because I'm going to talk about Professor Goel. This is his oration on the 113th Foundation Day of the Department of Surgery, KGMU, Lucknow. And sitting in the audience with him, it was again something really nice for me, and I told him that I'm going to put the slide in my presentation, and he consented. I am in the land of poets, authors, writers, the land that made Ghalib, that made Munshi Premchand come to fore. ऐसा आसान नहीं लहू रोना, दिल में ताकत, जिगर में हाल कहाँ. These are the opening sentences that I want to go through because I am talking about something we just heard about jigar, we heard about liver. I'm going to go a little bit away from it to the CBD and choledocholithiasis. We face it day in and day out. And really, I was very happy yesterday once I heard that they are doing laparoscopic Whipple's hair. So I bring you greetings from these fine gentlemen who are my faculty in Government Medical College, Srinagar, which again was built by the British in an old hospital, 1939, and these are my colleagues there. So this is the historical perspective. John Thornton, first CBD he did in 1889. Kahar, you know about him. He refined the technique. It was Halsted who operated his own mother for choledocholithiasis, another ethical issue that we must talk about. But unfortunately, he himself died because of a retained stone post-cholecystectomy. Then Robert McKeon was the first gastroenterologist to perform ERCP. The Japanese started it, but he took over in 1968. And of course, with the advent of laparoscopy came a new beginning, a new start. It was Philip Morey and Eric Mohe who basically gave us laparoscopic cholecystectomy, and they were gynecologists. They were not general surgeons. But they poked their instruments here and there, and they did laparoscopic cholecystectomy, and you know now it's the sky is the limit. And Patel JB was the first person to perform laparoscopic CBD exploration in 1991. I owe gratitude to this person, Professor Munir Khan, who is a urologist. Again, a urologist. The person who started laparoscopy in J&K long time ago, 1998, he started there. But it was not only lap chole. His vision was futuristic. He was ahead of his times. He, being a urologist, used his advantage of dealing with these instruments that they have, nephroscopes and everything, and he poked them into CBD. He went into pancreas, he went into colon, he went into stomach. He did everything that was possible at that time. Imagine we are talking of 2000, we are talking of 2006, we are talking of 2010, and he was way ahead of his times. So my salute to him. He was an ideal for me, and I tried to emulate something that he has set up. And now I'm going to take you to the topic. So you know it's something, because I'm addressing most students here, it's nice to see them all looking bright in the morning here. So you know ultrasound, it is the first investigation that obviously will be done, and only if we have some issues do we go to the secondary line of imaging, that's CCT, MRCP, EUS. Here's something that I have to tell, that the two investigations like ERCP and the PTC, they are both diagnostic as well as therapeutic. So ultrasound, commonly obtained, initial investigation, easily available even at the district and sub-district levels, then very cheap, non-invasive, good sensitivity, and inexpensive and quick to perform. But only thing is that it doesn't pick up all the stones, especially if the duct is not dilated. The first thing is that the ultrasonographers will look for, is the duct dilated? Then they start looking what is the cause of obstruction. So it's around 60 to 70% of the times that they give us a clear-cut diagnosis about this. It's operator dependent. Certainly there's an issue. The more senior person, the more experience, the better they are at giving us the diagnosis. But we know we are going towards an epidemic of obesity. Sar is doing bariatrics here. That is really wonderful to hear about that. And we have issues because patients are obese. We cannot see the organs as nicely as we could in a lean or thinner patient. and intraluminal bowel gases they are under, they also cause issues while imaging by ultrasonography. Endoscopic ultrasound is not readily available. I would say that not every center has it, but if it is available, it certainly increases the yield. It can make you very secure, and it can even give you FNA. You can do that, and ultrasonography, you can use that. So this is a beautiful picture of a dilated duct with a stone which has a posterior acoustics, and this tells you that yes, this patient certainly has issues in his CVD. Then MRCP, very good investigation, non-invasive. We can visualize the whole of biliary tree, and it avoids the complications of ERCP and PTC. ERCP, PTC, because they are both therapeutic, they are invasive. They have issues which we'll be discussing later on. And the only thing is here that it's non-therapeutic. You can't do anything, you can only diagnose. That you must be knowing. So this is a wonderful picture. You can see almost everything, even small details you can see here. You can see the CBD, then you can see the hypodense shadows in the distal CBD just above the ampulla. Then you can see the pancreatic duct. Just look at the length of the cystic duct. It's very, very long, and sometimes this can lead to retained stones. So the investigation that is now taking over in majority of the cases of choledocholithesis, the therapeutic measure that is taking over the cases of choledocholithesis, that is ERCP. It is used for biliary obstruction distal to the bifurcation of hepatic ducts. It gives a better result there because it is indirect. We are not visualizing the ducts unless we have a spyglass. It's a new in this improvement in the ERCP era that you can now go into the ducts. So they can go into the cystic duct, they can go into the left duct, right duct. But it's very costly and operator dependent upon again. And ERCP both has a diagnostic as well as a therapeutic role. You can do sphincterotomy, job done, especially for a stone in the lower CBD. If there's a stent, you can put in strictures, you can just put a stent there, then you can do drainage, especially in pancreatitis and cholangitis. But something very important before you refer the patient for ERCP is that you have to be absolutely certain what is the coagulation profile, because this is an invasive procedure, and you want to be sure that you do not send a patient whose PTINR is deranged and you can have excessive bleeding on table. Then the problem with this investigation that there is morbidity and mortality. Sir talked about the donor liver morbidity and mortality. Here also we have a definite morbidity and mortality that I'll be talking about. It causes pancreatitis, we do see it. It causes cholangitis, there is bleeding, and sometimes there is duodenal perforation, unfortunately. So here you can see the ampulla of Veta very nicely, and a filling defect in a dilated ductal system that has been done through ERCP. PTC is something that our friends from radiology have started, and they're doing it for a long period of time, but it's better for problems that are higher up, above the confluence. The higher the problem is, the better they can deal with the problem, and they can even take out stones. They can dilate the tracts, but again, it is an invasive procedure. You require to have very close liaison with the department to get the best out of them. And certainly your personal humbleness in asking that we need this, sir, please, helps in getting you the best possible results. So, stones in CBD, who is going to attack? Is it the surgeon? Is it the endoscopist? Or is it the radiologist? It's all overlapping, but there is a definite algorithm. It's not that everybody will do everything. No, it's not like that. Surgeons, they have a definite role. Radiologists, they have a definite role. And the endoscopist has a definite role. Of course, because I am a general surgeon, I'll again go to that. that laparoscopic CBD exploration is one of the best procedures available for management of choledocholithiasis. And who says this? Not me. It is the American Society of Gastrointestinal Endoscopic Surgeons, Guidelines 2014. So I'm keeping myself very clear because I know I have surgical gastroenterologists in front also. So now we have diagnosed. What do we do after that? Because now there are 3 departments looking after the patient. Do we send to the endoscopist? Do we do a radiological intervention? Or do we take the patient up? And how do we take the patient up? Open, of course. I have been trained in that. I did it for a long period of time. But with the passage of time, things changed. We understood that laparoscopy is affording a lot of goodness, of well-being to the patient, and we shifted over. And we shifted over with this intention that do no harm. That is the principle sir was talking about. Once you go above it, it's a simple CBD stone, but now we are managing complicated stones. What do we do there? Can we do drainage procedures by laparoscopy? The answer is big yes. So choledochoduodenostomies, hepaticoduodenostomies, everything can be done provided through things here. You must be very patient and you must be experienced enough with endoknotting and endosuturing. If you do not know these 2 things, you are going to land in trouble, the patient is going to land in trouble. So it's my request to all my juniors here, please spend time in the endolab. It's going to help you in your life. It is going to help millions of patients. So whenever you get a chance, go there, start fiddling with the instruments. So I talked about ARCP, certainly a very good investigation and a therapeutic measure, but what is the morbidity? It's nearly 16% at 30 days of the intervention, and mortality is hovering around 1%. So that is a bit high. Once we consider that you're going to send a patient and second day you're going to have an issue, what has happened, why did you send us there? So PTC, we don't have much experience of this, but it's a good investigation in good hands, especially in those cases where you cannot access the CBD, you cannot access the ampulla. We have done a RYGB, what do you do there? So that is the investigation and method of choice for those cases. Now laparoscopic CBD exploration. Very strange that I straight away jumped to laparoscopy. Why not open? Why not open procedures? Why am I not talking about that? Because the videos that I'm going to share with you will certainly make this endeavor of not talking about open very clear to you why I did not talk about open. So LCBDE, transcystic, only some specialized centers do it. Transductal, any one of you can do it. Transcystic, these are the indications, a smaller duct, but the cystic duct has to be wide or it has to be dilated. You can't just go in, and you need the instrument, the cholangioscope, the flexible cholangioscope, which can go through the cystic duct. It's not so easy as I am presenting it here. And preferably for proximal stones, you can't do it. Multiple stones, very difficult. Then abnormal CD insertion, not possible. Transductal, the procedure of choice, very easy, very straightforward. If you know the anatomy, you know the vascularity, you know the adhesions, you know what's in that area, what are you going to fiddle with, and you should know when to call for help. That is another point that I want to stress. Important is that you can start any procedure. The thing is, success is once you are able to complete it successfully without causing more harm to the patient. So any CBD which has a diameter of more than 9 or around 16 mm, you can certainly do it. Multiple stones, abnormal anatomy, anything that can come in the way. And once you have opened the CBD, what do you do after that? You can primarily close it if the patient has had an ERCP and the employee is defunct. You can just close it back. Or you can put a T-tube. We started with T-tube, but we found that the morbidity was a bit high, and we shifted over to endobiliary stents that we put over a guide wire. And I am thankful that I have a urologist here, because most of the things we have taken from them. We use their guide wire, we use their nephroscope, we use their cystoscope, and we put it into the liver system. So, advantages of LCBD or ERC and endoscopic sphincterotomy. British Society of Gastro and Endoscopists Guidelines 2007, it's equally efficacious. So I'm talking literature, it's not my experience. So this is the transcystic laparoscopic CBD exploration. I think all of you are intelligent enough to understand that navigating the tortuous cystic duct with a flexible scope is not going to be easy. It's not easy. It does give trouble if you don't have the proper equipment, and we do not do it. It's better to send for ERCP. So this is the other picture of that. Okay, now you can see. So this is one of the videos that I want to share. Now you can see the patient already has had cholecystectomy, and there are a lot of adhesions in the region. L-hook, ligashore, harmonic, and the best instrument that I like, the suction irrigation cannula, hydrostatic pressure that helps me to dissect. You can clear adhesions calmly and coolly, because first important thing is that you have to be very clear with the anatomy. You can see the duct is very thick, and scissors, cold scissors, you can use them, you can use anything as long as you know what is the vascularity in that area, you are well versed with that. Once you have distinguished that this is the area that you have to work with, this is the CBD, you have to be very precise with that. You can even use suction, then you can use a simple L-hook, mark the CBD in a vertical fashion, because the vascularity is coming from 3 and 9 o'clock position, and then mark it, then open it, and what do you get? Muck. You get some amount of pus. Oh, something is there. What is it?
Press.
So it's a stent, sir is right. But another stent is coming out. So the friends in gastroenterology had put in 2 stents, and since we were going to proceed ahead, now why are we still continuing? I think we have done enough. Why am I trying to push everything up from the duodenum up? So then that means something more is there. So obviously we had to widen the incision on the CBD, taking care that you do not go too posterior, you do not injure the vascularity of the duodenum. Then you can use a simple suction irrigation cannula. I really love this instrument. It can do wonders, it can clear the field, it can guide you, and after that, what is this coming out now, this wire-like thing? So this was a stuck Dormia basket. Because the stones were big, they were doing ERCP, they tried to pull out the stones. Unfortunately, you can see it has broken there in the CBD, and then we came and we attempted to remove it. Now the problem arose, can we pull it back? If we could pull it back, everything fine. But because the stone was stuck, we could not pull it back. So we thought, okay, let's take it out through the epigastric port, cut it. Now we are looking for something to cut it. This thing is so hard that we needed the scissors that a tailor uses, you know, that big scissor. That only could cut it. Unfortunately, we did not have a wire cutter in the OT because it's a general surgical OT place. We didn't have it there. And then only we could withdraw it. Imagine the patient with that wire through his mouth, what he must have been going, it was a she, what she was going through. Okay, something very peculiar in our region, ascariasis. Once we didn't have the facility for ERCP, this is what we used to do, especially if the worms would be dead and the endoscopist, still they can pull it out only by endoscopy if it is across the papilla. That time the patient has severe pain. So if you're sure that the patient has a live worm, send for endoscopy. Otherwise, you can remove it nicely by laparoscopy. Situs inversus totalis. The gallbladder is on the left side. Everything is
Recording in
transposed.
progress.
And problem now is they attempted 3 RCPs. They could not help the patient because the stones were big, as you will see. And you can see from the extensive adhesions what this case must have been like. We could not initially differentiate where the gallbladder is ending and where the CBD is. Only this groove was there that made me sure that no, we are at the right place. So we used harmonic scalpel, went in, cut the CBD open, and what did we get? So 1 stone, fine. Give a wash. It's old stent. You can see because it's so dirty. It's not coming out. What was the reason? The reason was this boulder that was stuck. And once you look inside the CBD with a nephroscope, what do you see there? There's a huge cave-like structure just above the papilla. So obviously it was a difficult case for the endoscopy people to deal with. So now once you have gone into the CBD, what are the different methods by which you can remove the stones? Simply, another instrument from the urology, the tri-prong, one of the best instruments. Then you can use pneumatic lithotripsy, again from them. You can use laser, again from them. So I told you we have very close association with the urology people, and they all obviously help. If you have a Dormia basket that I have just shown you, or a Fogarty catheter, or even ureteric forceps, all of them, even a Crochet-Olmy forceps can help you in removing the stones. Now look at this. Something is vibrating at very fast speed. Sir will tell you that it is a pneumatic lithotripter, and we break the stones, especially the big ones, into smaller pieces, and then we take them out by simply a tri-prong forceps that goes along the side of the nephroscope, holds the stone and takes it out, and does a very good job. So what's new now? Why am I here? I'm here because I'm going to talk about this particular instrument. Can you see this, sir? This is your flexible cystoscope, very small sized, and it has a portable video screen. A portable video screen, you do not need another system to go into the CBD. So it is flexible. You can use non-crushing forceps, go into the CBD, and then you can go into the distal. And this is the proximal side. You can see both the ducts there very clear. On the distal side, what do you see? There's a stent there, and there's a stone. So imagine going like this, because the problem with the rigid nephroscope, as Sir must have told you so many times, once you move it, there's a torque, and you can rupture the CBD. So this is what helps. And now, what we are using a laser fiber through this cystoscope and breaking the stone into smaller pieces, one burst, and after that you can use the other instrument. And this is what we love to see, a clear picture from inside of the duodenum. This is inside of the duodenum that you're visualizing. Why have we been able to go in there, into the duodenum, through the CBD? Because once I withdraw, now you can see the papilla. The papilla has been made defunct. And once I withdraw further, then turn the nephroscope or cystoscope, we go into the ducts. So we will have the main ducts there. There is some amount of muck, and then we go right and left duct. Then you see the segmental ducts, smaller ducts, and one more area. See the bile coming? See the bile coming? That means your liver has started to function there if it was obstructed. This is such a great feeling once you do this and you see that your patient is benefiting. So now I talked about the simpler cases. Now we have a dilated duct. What do we do there? Can we just simply close it back? No, it's not so. Because problem with these ducts is, if it's a wide duct, that means it has lost its ability to push the bile down, and once you close it back, certainly you will have problems, reflux cholangitis and all that. So this is one of the cases done by my colleague, and they just removed 61 stones from the CBD, and our second year postgraduate, she has a flair for this art. She made this stone art. You can see the gallbladder, on the right duct, the left duct, and this was put on Twitter by him, and it garnered a lot of views there. Once you're doing laparoscopic hepatocogenostomy, choledochordiostomy, most important thing is that your anastomosis has to be minimum 2 centimeters, 20 millimeters. Do not do an anastomosis unless the duct is dilated. The problem lies with the body's response. The body's response is such that whatever anastomosis you will make, it will shrink. It will be reduced by 50 to 70%, and we at places there, usually we would like to do a choledochordiostomy because we are keeping that area open if we have to do an intervention afterwards. Can I have water, please? Excuse me. Can I have water? Sorry. And of course, some syndrome is there. So this is the port position. Now you see a different kind of port position. You have a liver retractor, Nathanson's liver retractor. That makes your job easier, and it's easier on the postgraduates who constantly have to hold the liver up, and then you start feeling irritated once it falls down because it's quite slippery. This is one of the best instruments. Then the 2 ports on the left side of the patient. One is a 12 mm and one is 5 mm. You go on the left side of the patient and you operate from there, and it becomes very easy, especially if you have kept the leg split, because then you can move around. So now gallbladder distended, adhesions, adhesiolysis done, adhesions on the gallbladder taken care of, going now more towards the CBD. So partially we have dissected the anterior and posterior areas of the gallbladder. The duct is obviously wide here. We have clipped it. The artery is taken care of at the start because that gives you more traction. You don't keep the traction like that. And again, I stress that I like to use the hydrodissection. I feel it's a lot safer. So now we are going posterior to the common bile duct. What do you see here? That is the portal vein. That's the area you're working with. So you have to be very precise with your dissection there. You do not flinch there. You do not make a mess of it. Obviously, the duct is very wide. So use umbilical tape, because once you use it, you clip it, then you give traction and dissect nicely, easily, posterior to that. So once you cut it fine, then the inferior aspect, the distal side, is closed back because the plan is to do a hepatocogenostomy. And I want to stress here that we are mostly using braided sutures for the last 10 years now. We started with coil, then we shifted to V-lock, and we are also using Stratafix. They give excellent results because suturing in laparoscopy is not easy. So what do we do now? Now we are going into the ductal system, and we see that it's very clear, everything is clear. But posterior dissection here is a must. If you do not do this, you will have traction on your anastomosis, and that is going to leak. Especially if now you're taken the jejunum 40, 45 centimeters away, make a hole in the mesentery. And another wonderful instrument that we have is this endo stapler. Certainly, it makes the job so easy. It makes the job so perfect. So take the distal side, do a retrocolic. We do not do anticolic. We do retrocolic through the mesentery. Make a small cut in the smaller cut as compared to, of course, you know that. I don't have to tell you that. And then anastomose we do a running suture, but we use two threads, one for the posterior side, and once we have reached the medial aspect of the CBD, we stop there, then we put another thread. That increases the efficacy. But if you are doing a choledochal cyst, nothing doing, your sutures have to be interrupted by Vicryl, nothing doing. The leaks that we have had in laparoscopic hepatochoduodenostomy have been in choledochoduodenostomy because we were using this kind of thread. So after that, just close the, suture this, close the mesentery to prevent herniation, and the job is done. So retained stones itself is a topic. It would be out of place to now go on to that, but ERC, T-tube cholangioscopy, if we have done it, then PTC or observance is the order of the day. So before I sign off, I would like to invite all of you to our annual Jakasikon 2025. That will be held in Pahalgam, not in Srinagar. Pahalgam is a hill station. You must have heard about it. It's a wonderful place. 23rd to 25th of August, I am incidentally at the same time chairman of the Jammu Kashmir's chapter of ASI. So that's my invitation all to you. For postgraduates, it's going to be an academic extravaganza, and for the seniors, please do come and enjoy Pahalgam and Kashmir. It's a wonderful place. I leave you with this picture. It's from Gulmarg. I like to ski. I like to play cricket. I like to play badminton. I like to swim, and I like to live. And I want you people to do that. Thank you very much. I hope it has been of some use to you all. Thank you.
Thank you, Dr. Iqbal Salim, for a wonderful presentation and the beautiful videos that you showed. I think the most important message that you gave was that interdisciplinary collaboration, you know. So lithotripter, holmium laser, baskets, stents, so all these things we use. And I think your collaboration with Dr. Munir Khan, that you know, your mentor. So I think that gave you ideas, and I think you have used all those ideas very efficiently. I was just wondering, gallbladder stones are cholesterol stones. They are soft stones because our urinary stones are calcium stones. So they are easier to break and they are more stable, and you can, but maybe the cholesterol stones are softer and probably difficult to fragment.
So we have two types of stones there. One, obviously, you said about cholesterol, but post-ascariasis.
Okay.
Because we have biliary ascariasis in plenty. You will see almost 2-3 cases every week.
Okay.
Those stones are really, really hard. You can hit somebody on the head and he might get a bump for days.
Okay.
Okay, so that's where we use these. In fact, we now go into the pancreas, especially into the uncinate process with this flexible cystoscope. There also we break the stones. It's just a matter of understanding the anatomy, the matter of understanding the equipment, how to use it to make your life easier and to make the patient's life easier.
So we have flexible ureteroscopes also. So now you were
My
using
next target will be
flexible
that.
cystoscope. So they are much thinner, you know, if you want to take them higher. I think that can be...
I think I'll just ask Sonkar sir.
Okay.
Okay, sir.
Thank you so much.
Thank you very much,
so
sir.
much.
Thank you again for inviting me.
Thank you. Thank you. It was
Thank
a
you,
pleasure.
sir, for nice presentation and comprehensive talk. Thank you, sir. Thank you.
So thank you very much.
Thank you, sir.
And
Thank
we
you.
are going to use that
Aerotoscope.
That is the next step, and I'm sure that Professor Sonkar will certainly get this equipment. It's 8 lakh rupees. It's not a big issue. And it's can be used
Here we use choledocoscope and nephroscope, sir, actually, for retrieval. Yeah.
disposable, 10 cases, 12
Yeah.
cases with one this cystoscope, and the results you can see. You will never enjoy this.
Yeah. Thank you, sir.
Thank you. Thank you.
Thank you, sir. I request everyone to be seated. We'll start the inauguration ceremony in few minutes.
happy belated Mahashivratri to everyone. This one's for Shiva. शिव कैलाशों के वासी धौलीदारों के राजा शंकर संकट हरणा Happy belated Navratri to everyone. This one's for Shiva. शिव कैलाशों के बसी धौलीदारों के राजा शंकर संकट हरणा शिव कैलाशों के बसी धौलीदारों के राजा शंकर संकट हरणा तेरे कैलाशों का अंत न पाया तेरे कैलाशों का अंत न पाया अंत बेअंत तेरी माया ओ भोले बाबा अंत बेअंत तेरी माया सजदा चोला ते डोरा शिव जी नु सजदा चोला ते डोरा गौरा नु सजदा तुशाला ओ भोले बाबा गौरा नु सजदा तुशाला शिव कैलाशों के वसी धौलीदारों के राजा शंकर संकट हरणा Please excuse my voice, I'm a little under the weather, but I wanted to dedicate to Shiva. As my Guruji also had the name Shankar in his name, I feel I'm always surrounded by Shiva. Happy belated Mahashivratri to everyone. This one's for Shiva. कैलाशों के वासी धौलीदारों के राजा शंकर संकट हरणा। तेरे कैलाशों का अंत न पाया, तेरे कैलाशों का अंत न पाया, अंत बेअंत तेरी माया। ओ भोले बाबा अंत बेअंत तेरी माया। शिव जी नु सजदा चोला ते डोरा, शिव जी नु सजदा चोला ते डोरा, गौरा नु सजदा तुशाला। ओ भोले बाबा गौरा नु सजदा दुशाला। शिव कैलाशों के वासी धौलीदारों के राजा शंकर संकट हरणा। Please excuse my voice, I'm a little under the weather, but I wanted to dedicate to Shiva. As my Guruji also had the name Shankar in his name, I feel I'm always surrounded by Shiva. belated Mahashivratri to everyone. This one's for Shiva.
शिव कैलाशों के बसी धौलीदारों के राजा शंकर संकट हरणा शिव कैलाशों के बसी धौलीदारों के राजा शंकर संकट हरणा तेरे कैलाशों का अंत न पाया तेरे कैलाशों का अंत न पाया अंत बेअंत तेरी माया ओ भोले बाबा अंत बेअंत तेरी माया शिव जी नु सजदा चोला ते डोरा शिव जी नु सजदा चोला ते डोरा गौरा नु सजदा तुशाला ओ भोले बाबा गौरा नु सजदा तुशाला शिव कैलाशों के वसी धौलीदारों के राजा शंकर
excuse my voice, I'm a little under the weather, but I wanted to dedicate to Shiva. As my Guruji also had the name Shankar in his name, I feel I'm always surrounded by Shiva. Happy belated Mahashivratri to everyone. This one's for Shiva.
Kindly keep your phones on silent, please. Thanks. Good morning, all. We are honored to have with us today a distinguished gathering of leaders and visionaries. Their presence adds to the special occasion of the 113th Foundation Day of the Department of General Surgery, King George's Medical University. It is my honor to welcome you all here today. May I now invite all the dignitaries to the stage. I welcome the Honorable Chief Guest, Shri Parthasarthi Sen Sharma Sir, Principal Secretary, Medical Education and Health of the Government of Uttar Pradesh, to the stage. We welcome you today, sir. I welcome Professor Sonia Nityanand Ma'am, our Honorable Vice Chancellor, to the stage for a floral welcome. I now welcome the Honorable Pro Vice Chancellor Ma'am, Professor Abhijit Kaur Ma'am, to the stage. I now welcome our respected CMS, Sabika Sir, to the stage. I welcome the head of the Department of General Surgery, Professor Abhinav Anronkar Sir, to the stage. I welcome the Professor of General Surgery, Professor K.K. Singh Sir, now to the stage. A very warm welcome to our respected Organizing Secretary, Dr. Parijat Suryavanshi Sir. We also welcome Professor Saroj Churamani Gopal Ma'am, a pediatrician par excellence and the ex-Vice Chancellor KGMU, to this special occasion. The lighting of the lamp signifies the removal of darkness and the ushering in of light, symbolizing knowledge, purity, goodness, wealth, and power. Let us mark this milestone with this auspicious activity. I request all the dignitaries to grace the stage for the lighting of the lamp.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति 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 असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति 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 असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति
Thank you, dignitaries. I would now like to request Professor H.S. Pava Sir, Professor of General Surgery, a skilled surgeon and a beloved teacher, onto the stage to address us all gathered here. Professor Pava Sir has always pushed the boundaries of what medical education is defined as in our country and has always strived to bring the best out in every student. We welcome you, sir.
So thanks. Very good afternoon, everybody. So our most respected Honorable Vice Chancellor and Chief Patron and President of today's function, Honorable Sonia Nityanand Ma'am, our distinguished Chief Guest for today, and Mr. Parth Sarthi Ji, Senior IS and Principal Medical Secretary and Health, our respected, very active and very considerate Pro Vice Chancellor Abhijit Kaur Ma'am, and our dynamic active CMS Dr. B.K. Ojha, and man behind this show, Organizing Chairman Dr. Sonkar, and Co-Chairman Dr. K.K. Singh, and Dr. Parijat. And I can see from here my ex-Honorable Vice Chancellor, Professor Saroj Churamani Ma'am, my teachers, R.K. Tandon Sir, Kuril sir, Dalila sir, to grace this occasion, and our most and all other respected teachers from other specialties and other departments. My dear friends, staff members, my friends from trade, last but not least, my beloved residents. My duty which is passed upon me herein from Dr. K.K. Singh, because he had a very bad sore today, bad throat. So I'm welcoming all of you here in 113th Foundation Day of Surgery. I take a great privilege to welcome everyone one by one. So Chief Patron and President today, our Honorable Vice Chancellor, ma'am, you are always an inspiring source for all of us, and your presence constantly reminds us your vision, action, and your energy you had. Ma'am, your meticulous, sincere, and positive way of thinking with humbleness always inspires us. We are indeed fortunate to have you here in spite of your very busy schedule and to grace this occasion. Parsarthi sir is known for his very, you can say, the bright disciplinary and management skills. He is well known for like the things which are very difficult, simple solutions for difficult things. And he's always with a very positive attitude and always supporting us. So, sir, thank you very much for sparing time and joining us here. Further, I thank you for Ma'am Abhijit Kaur ma'am. She is always here to support us. Dr. Ojha is always there to support us. And Dr. K.K. Singh and Dr. Sonkar is working hard for the department and planning this program. So, I will also take opportunity to welcome our orators here. We had in the morning 3 orations. The first S.C. Mishra Memorial Oration was given by Dr. Patricia J. Newman. She is Professor Emeritus at State University of New York, Upstate Medical University. She was founder of the Association of Women Surgeons of American College of Surgeons, and she was also President of American College of Surgeons. Dr. P.C. Dubey Memorial Oration is delivered by Lieutenant General Pankaj Rao, sir. Welcome, sir, and thank you very much. He is Director and Commandant Armed Force Medical College, AMC, Pune. Dr. T.C. Goel lecture was delivered by Dr. Iqbal Salim. Sir, thank you very much. He is Head Department of Surgery, Government Medical College, Srinagar. We are really blessed with the presence of various dignitaries. Today we are here. Their presence is here really valuable. As Foundation Day reflects our beginning, remember the journey since inception, and then this is definitely a day for, we can say, introspection and for further planning, for future planning. Let's take a place to work earnestly to grow, for the growth of department and university. And in all aspects, we have a proud past, and let's resolve and make the future bright. So we should work hard and we should take this pledge. Finally, on behalf of the assembled here, I extend my heartfelt welcome to all dignitaries once again. And our wonderful gathering really belongs to Noble Group. It may not be possible to name all of you. It is indeed a pleasure to have you here today. I extend your warm welcome and thank you all once again. Thank you very much.
I would now like to invite our respected Head of the Department of General Surgery, Professor Abhinav Arun sir, to deliver the annual report. Sir has been a guiding light in the field of medical education, and year after year, his vision and effort bring the Department of General Surgery close to the precipice of cutting-edge surgical technology. It is a pleasure to welcome you, sir.
A very good afternoon to all of you. Honorable Chief Guest, Shri Parsarthi Sharma ji, Principal Secretary, Medical Education and Health, Honorable Vice Chancellor, Professor Sonia Nathan, Madam, Abhijit Kaur, Madam, Pro Vice Chancellor, Professor Ojha, CMS, Professor K.K. Singh, Parijat is Organizing Secretary. He is the Dulha and Damad and Bharati and Sasur of this whole conference, Parijat. Sir, and Honorable Chunamani Gopal ma'am, Professor Kuril, Professor Me, Professor Chaturvedi sir, Dalela sir in the audience, and Tandon sir, Pankaj Rao sir, and Mir sir, those who have come from Kashmir and Pune respectively. I'm indeed grateful to see you here and the member of press and the audience. Celebration of 113th Foundation Day of Surgery Department is much more than a reflection of our journey since 1912. You are aware that this is one of the oldest departments to start with imparting MBBS and MS training. This year, the milestone carries even greater significance as we celebrate not our rich past, but also the exciting future that lies ahead. And here's what makes this occasion truly special. Today, we commemorate our century of groundbreaking innovations, unwavering dedication, and excellence in surgical care. Our department has long been defined by a pioneering spirit, one that laid a solid foundation for everything we have achieved so far. This legacy is a testament to the enduring commitment of all those we have come before us and continues to inspire us as we move forward. Our department is much more than just a professional entity. It is a close-knit and supportive family. Every member, whether a seasoned surgeon, an eager resident, or a dedicated staff member, contributes in their own unique way to our collective success. This year, we are not just celebrating our past, but also our shared vision for the future. We have built at something extraordinary together, and I'm proud to stand alongside each of you as we continue to grow. Foundation Day offers us invaluable opportunity to reflect on our achievements and honor the contribution of every individual who has shaped our distinguished legacy. This year, we mark a significant milestone with the delivery of SSI Mantra Make in Robotics, Surgical Robotics System under CSR by Powered Corporation of India. Second is the provision of a new department building, entirely new building, which is going to be one of its kind in whole of the country, having a building management system, having convention center style lecture theaters, having ICU, HDU, and everything under one roof. And what you can think of in a modern setup, in a modern corporate hospital is going to be better than that. And I'm grateful to the present government and Principal Secretary for this. I will just briefly present the report because I know you people are short of time. But this gentleman, Colonel W. Selby, he's not here. He started the department and he's buried in the residency here. He was IMS, he worked in Afghanistan, and he was first surgeon, he was first head of Department of Surgery, and he was the principal also. And then we were the first forefront, we started neurosurgery, and when it was a part of general surgery. Dr. Bohal started first laparoscopic cholecystectomy, endoscopy, mammography, and so on and so forth, sir. This is the department, whole department before you. And the first one, Professor T.C. Goyal, is emeritus surgeon. He is still alive and healthy. He gives us his blessings every day, and he is a walking dictionary and walking encyclopedia, sir. He still writes, and he still written a textbook of surgery in Hindi. And then these are our other faculty members. So this is the department faculty, department-wise faculty and distribution. We have nearly 300 beds, sufficient for NMC, and we have 8 working units, and we have 7 professors. And this is the achievements of our faculty members. Everybody is gainfully utilized by the university administration. And wherever university administration or department activities they are utilized, this shows that the university has immense faith in the faculty of surgery department. And I'm immensely thankful to you, ma'am. Thank you once again. Dr. Pahwa has been awarded Best Senior Teacher Surgery Award by Association of UP Chapters of India. And on the right side, you can see that he has he has several administrative responsibilities as well. Professor Suresh Kumar, he is working as medical superintendent. He has been awarded Vice Chancellor's Appreciation Award in a recently held function. Professor Avnish Kumar, he has been awarded R.L. Subharti Oration Award. He was been awarded $10,000 worth American College of Surgeons International Guest Scholarship. He would be traveling to Cleveland and other places. And then he has already been awarded Severance Hepatopancreatic Biliary Fellowship by Korea. Professor Suren Kumar is Human Resource Faculty in charge, very important man, and we all, dance around him, begging him, pleading him to please provide us some few more employees. Professor Jitendra Kumar Kushwaha has got 3rd Best Faculty Paper Award, got Dr. Geetika Nanda Singh Best Award Paper, 10,000 rupees, and Dr. Faraz Ahmed, the administrative store in charge of Department of General Surgery. Dr. Ajay Kumar Pal, he got Young Surgeon Award by ASI of India and Best Faculty Paper Award in ESICON, Association of Surgeons of India Conference. Dr. Soumya Singh got the Society of Elementary Tax Coaching Scholarship, Traveling Grant and DDU, and she's also the Departmental Nodal Officer for Biomedical Waste Disposal and does a good work. And rest of the people you can see are gainfully utilized in some way or the other by the university or the department. Dr. Kushagra Gaurav has received Popular Young Teacher Award several times, travel grant by SERB to attend American conference in Washington, and fellowship travel grant in 14th European Breast Cancer Congress. Our residents are also not lagging behind. They have got best paper, free paper award, and so on and so forth. And Dr. Shiva has got many things to his credit, and I think it is just the beginning. So the mandate of the department is to teach MBBS 250 every year, BDS 100 every year, MS Journey 24 every year. And besides this, we also, over and above, we have 3 PDCCs in head, neck, breast, and minimal invasive surgery, and fellowship of thoracic and anorectal surgery. This is the infrastructure, teaching and learning. These are all the pictures, and we have also used them in NAC. The this is the endotrainer lab where the resident has to undergo training, and then he moves on to do laparoscopic surgery. Infrastructure, post-operative HDU, OTs, and other things. OPDs, consultation, specialty clinics. Sir, this is just a graph. You would very well understand that department sees 6,058 patients every year in the OPD, and we admit 8,976 patients every year. This is a huge figure. And so another thing is that you would see the graph. It shows we operate a major 4,796, nearly 5,000 major surgeries and 21,665 minor surgeries. It's a huge, huge load to cater. And this, if I remember Dr. Gupta, madam, who was Vice Chancellor, he said, Abhinav, this whole spectrum of surgery, whatever you are doing, befits the university, not a department. And this is what I'm once again quoting from him. We do nearly every subspecialty of surgery, and we are nearly good at it, and we receive a good amount of patients also. Publications, we have a good number of publications, good number of research publications. We have MOU to conduct Royal College of Surgeons of Ireland party examination. We had a moving relationship with Pavia University, sir. It is a 1,200 years old medical university, which imparts, we had a relation with them. We had 6 and 7 faculty members have been there, and I'm also part of the Erasmus K Action 1 Professor Moving Fellowship there. This talks about the same thing, some extracurricular Teachers' Day celebration, blanket distribution, blood donation camp, welcome of the first year, and breast cancer awareness. And then, sir, we got this Essentials of Vascular Access Anesthesia course, Isha workshop, and this is patented on the name of department also. We have a 6th module where we teach residents how to do surgery, use the staplers and other things. So, sir, this program, Foundation Day, you must be aware that we celebrate because we got the present building when we are housed. It was 1955. And we celebrate, doctors celebrate everything with teaching program, academic program. So this year we got more than nearly 140 registrations were there. 40 or 50 were from outside of KGMU. 4 is the education program. The theme was knowledge is the best defense. And the more educated you are, the more competent you are for the future. And organ-based discussion, case discussion, workshops, and the focus was on workshop, putting chemo port, doing breast ultrasound, two-cut biopsy, tendon repair, vascular repair, bowel anastomosis, endotrainer sessions, and post-representation for the postgraduates. These are some pictures of the postgraduate program. It was hugely successful, current pictures where they were trained till yesterday. And this year has started on a very good note. Rather, I would say last year also it started on a very good note when the government and you, sir, were kind enough to sanction a whole new building to us. And this year we also got a robotic surgical system, Make in India. It is SSI mantra. And so this fulfills our long pending demand. And it was Power Grid Corporation CSR initiative which got this to us. And there was also very positive push from the Honorable Vice Chancellor that she also said, yes, please go ahead. She took her time, then she said, please go ahead and just go for it. Just go for it to see that it comes. So this is the picture of the plaque which is in the present building, 9555. Shri Chandbanu Gupji inaugurated it, Honorable Chief Minister then. And sir, special gratitude to Government of UP, the Honorable CM, you in particular, deepest regard to Department of Medical Education and the University Vice, and eternally grateful to the University Administration. Madam, under your guidance, we hope that the department will soon see the day of light of the day, sorry, and we will soon be embarking on a path to development. Sir, हमेशा हम लोग, whenever we call people like you and Honorable Vice Chancellor, उनसे कुछ ना कुछ मांगते हैं. And this year, it's going to be different. We are not asking you for anything. We are asking you for blessings. और ब्लेसिंग्स ये हैं कि सर लखनऊ में तो आप nobody knows सर लिखते बहुत अच्छा है और मैं हमेशा जब भी टाइम्स ऑफ इंडिया में लिखते थे तो मुझे सोचता है कि वो टाइम कहाँ थे इतना लिखने का आता है. सर यू रिमाइंड मी ऑफ लव वर्मा जी, ही वॉज फ्रेंड ऑफ माई फादर और तो बच्चों के प्रोग्राम में आते थे, वो भी लिखते थे. ही इज एविड रीडर, ही राइट्स और ये लिखते भी बहुत अच्छा है. और लखनऊ में है तो सर लखनऊ है तो महज गुम्बद मीनार नहीं, सिर्फ एक शहर नहीं, कूचा बाजार नहीं. इसके दामन में मोहब्बत के फूल खिलते हैं, इसकी गलियों में फरिश्तों के पत्ते मिलते हैं. और नहीं सर, ये शायद मदार लखनवी का है और ही वॉज अ वेरी नोन शायर. और पुरानी लखनऊ में उनकी कब भी है, कितने लिखा था कि वो साफ कराना है. इनसे बचवाना सर से मुश्किल है क्योंकि लिखते पढ़ते बहुत अच्छे हैं. इंग्लिश में हिंदी इनका फोटे है. और सर हम लोग अंग्रेजी में बोलते भी अग्री टू डिसएग्री, वेरी कॉमनली कहते हैं. तो एक शेर और भी है यहाँ पे, बड़ी मुश्किल से आते हैं समझ में लखनऊ वाले. सर बड़ी मुश्किल से समझ में आते हैं लखनऊ वाले, दिलों में फासले लब पर मगर आदाब रहता है. दिलों में फासले लब पर मगर आदाब रहता है. और तो बस मैं ख़त्म कर रहा हूँ. आई स्पेशल थैंक्स टू सर, मैंने बोला आज आपसे कुछ भी नहीं मांगना है. ऑनरेबल वाइस चांसलर, आपसे कुछ नहीं मांगना है. आप लोग हमेशा कुछ ना कुछ देते रहते हैं, हमेशा मांगते रहते हैं. आज सारे सपने पूरे हो गए मैडम, सारे तो नहीं, मेजॉरिटी पूरे हो गए और मैं उसका आपसे दिल से धन्यवाद करता हूँ. और सर आपके लिए मेरी बांग्ला माफ़ कीजिएगा, थोड़ी टूटी टूटी है. আমি ওর আমাদের সম্পূর্ণ সৌজি ডিপার্টমেন্ট আপনাকে হৃদয়ের থেকে ধন্যবাদ জানাচ্ছি এবং আমরা আপনার জন্য সমৃদ্ধ আর একতা সুষ্ঠু ভবিষ্যের কামনা করি. और सर लखनऊ के हैं तो लखनऊ का एक शेर आपके और मैडम आपके हुजूर में पेश कर रहा हूँ. हालांकि थोड़ा इवनिंग वाला ज़्यादा स्टाइल हो जाता है. शुक्रिया तेरा, तेरे आने से रौनक तो बढ़ी. और सर आपके लिए भी है, शुक्रिया तेरा, तेरे आने से रौनक तो बढ़ी, वरना यह महफिल जज्बात अधूरी रहती. सो काइंड ऑफ यू, थैंक यू एंड ग्रेट थैंक यू टू बोथ ऑफ यू. थैंक यू वेरी मच.
Thank you, sir. I would now like to request Professor B.K. Ojha, sir, to regale us with some words of wisdom.
Dignitaries on the dais, off the dais, ladies and gentlemen, today I congratulate the Department of Surgery for completing 113 years of academic years in KGMU. As you know, that general surgery is parent department for most of the broad surgical specialty as well as super specialty. So it is like father figure for most of the surgical department. And it is like, if you say general medicine and general surgery is like heart and brain of an institution. And KGMU is very proud of these two departments and their functioning. And my best wishes for very good future of the department, and congratulations again. Thank you.
Thank you, sir. Now, I would like to request Professor Abhijit Kaur ma'am, our respected Pro-Vice Chancellor, to grace the podium and bestow upon us some words of wisdom gathered over her rather respected and long tenure.
Good afternoon. I actually don't know where to start from. feeling extremely nostalgic, taken back to 1982, when Professor P.C. Dubey was the head of the department. Dr. Tandon was there. And we used to have such wonderful classes. The evening teachings in general surgery and general medicine were par excellence. Our examination also was taken in such an interesting manner. I remember for my final exam, Professor Dubey picked up the fibula and he hit it on the right side of my leg and asked me, "What have you developed now?" That was the intensity of clinical teaching in this department. And as I hear from the students now, this legacy is still being carried on. I think this is the best contribution that we as teachers can do to our subject. To be involved in good clinical teaching, which is amalgamated with clinical research. It is difficult for surgeons and medical doctors, the physicians, to do basic research side by side, but there is no bar to clinical research. And this department is doing a fair amount of it. Without taking much more time, I wish the entire department, all the rungs of the department, the workers, the staff nurses, the office staff, without whom no department can adequately function. The resident doctors working so hard, the faculty who give it their best. To each one and the mentors, I play a good best wishes. May you all flourish. Thank you.
Thank you, ma'am. It is my honor to now invite our esteemed Vice Chancellor, Professor Sonia Nityanand ma'am, whose leadership continues to shape the future of our university, to address us. She is a great leader who is not only defined by the power she wields, but also by her ability to inspire, guide, and uplift all those around her. We welcome you, ma'am.
Thank you. All the dignitaries on the dais, our chief guest, Shri Parthasarthi Sen Sharma ji, who is the Principal Secretary of Medical Education and Health, the head of the Pro Vice Chancellor, Professor Abjit, the CMS, Dr. Ojha, the head of the department, Dr. Sonkar, Dr. K.K. Singh, Dr. Suryavanshi, and our ex-Vice Chancellor, Mrs. Saroj Chudamani, and many of the teachers who are sitting here, from Dr. R.K. Tandon to, Dr. Dalela and Dr. Arun Chaturvedi. I can also see Lieutenant General Pankaj Rao, who has given the oration today, and Professor Iqbal Salim Mir, who's also given the oration today. All the esteemed faculty members of the Department of Surgery and from the King George's Medical University, all the students and residents and staff of the General Surgery Department. सबसे पहले तो आज फाउंडेशन डे के लिए आप लोग सबको बहुत 113th फाउंडेशन डे के लिए बहुत बहुत शुभकामनाएं. The department has traversed through 113 years of glory. I remember as Dr. Abjit was bringing out, Dr. Dalela is sitting here, that we had excellent teachers in the past. Dr. P.C. Dubey, it's good to remember them because each one of them was talented in their unique manner and have contributed to in the growth and development of the department. Late Dr. P.C. Dubey, I would like to acknowledge him. Professor R.P. Sai, who is still there. And I must admit, his notes, his teaching notes, still I have kept very safely with me. The way he used to teach, it felt that a patient is in front of you. Professor T.C. Goel, he's still there. And of course, Professor Tandon is sitting here, late Dr. K.M. Singh, father of Dr. K.K. Singh. He's again a very great teacher, Dr. Dr. K.D. Verma. These were the galaxy of people that when we were students, were there. I'm glad, I'm very happy to hear the progress of the past 1 year, Dr. Sonkar. You've carried the tradition forward. And I would like to congratulate every single staff member who has contributed in this progress of last 1 year. Foundation Day aap log ka function hai. So congratulations to all of you. This Foundation Day has a special place today for two reasons. It kind of signifies the initiation, the launch of the new surgery building, which is going to be an expansion of the existing building with many new facilities in it. Of course, one feels sad in leaving an old building, but then this will be a new building with advanced infrastructure and the acquisition of the robotic surgery system. Dr. Sonkar says that he doesn't have any takes today. But today, I think I and maybe the principal secretary will have certain takes from the department. So it's the other way around. We want certain takes from you. The first take from the entire faculty of the department is, that's my request, is to resume the culture of evening teachings. Dr. Abhijit highlighted, and I've been actually speaking about it from the day I stepped back into this university, that this, at that time it was a college, of course now the university, is very well known for its evening teachings. And 2-3 departments, especially the Department of Medicine, the Department of Surgery, and I would say the Department of Psychiatry. In my time, the psychiatry was very active in evening teachings. So I would really, really want the surgery faculty to resume this culture again. Nothing to replace the bedside teachings which used to be conducted in the evening. That's my one request. And I hope in the next year, in your progress, you are able to present that this has been fulfilled. The second request is, Dr. Sonkar, the second request is, you acquired a robotic system. It's a cutting-edge technology for surgery. Excellent move on your part, excellent initiative on your part, but it should be at an affordable rate. Affordable. So that it can be available to the masses. And that's why I've set up this core committee. One of the main reasons, one of the members is sitting here, Dr. Ojha, who's the CMS, and Dr. Pava, I think he's also somewhere there. One of the main things is that the rates which are set for charging the patients must be done in a very strategic, intelligent manner that they are affordable to the patients. And my third take that I want from all of you is to elevate the research standards, the research output, I would say. And make your research India-centric. Look at the problems that we face here. The post-operative infections, especially from multi-drug resistant organisms. How you can tackle them, how you can bring down their rate. Because at the end of the day, preventive medicine is even more important than curative medicine. So these are my 3 requests from all of you to start the evening teaching, to make the robotic surgery available to the masses, and to increase the research. I want the surgery, I actually want to churn out surgeon scientists from King George's Medical University. And the surgery department will take a role for churning out these surgeon scientists. We had always clinician scientists. I want that terminology to elevate to surgeon scientists now. Look at Dr. Chunamani. She's sitting here. She is a surgeon. Dr. Kuriel is sitting here. Surgeons who are actually surgeon scientists. So Dr. Sonkar, this is something that you will start going in your department. So thank you again, and good wishes to all the staff for this foundation today. Enjoy your day, and congratulations for a very progressive report of the past 1 year. Thank you.
Thank you, ma'am. It is my privilege today to invite our esteemed chief guest, Shri Parthasarthi Sen Sharma Sir, Principal Secretary, Medical Education and Health, the Government of Uttar Pradesh, to address us today. His contributions and his dynamic personality have made a lasting impact to the field of medical education, and we are truly honored to have him with us on this occasion. We welcome you, sir.
Distinguished dignitaries on the dais, dignitaries of the dais, friends, excuse me for not naming each one by name. The Vice Chancellor has already done that. Today is firstly the day of celebration, a day of joy, that the Department of Surgery, KGMU, is completing its 113 years. On 1912, the department started. Just imagine 1912, the First World War had not yet started. The Austrian Habsburg Empire was still there. The Ottoman Empire was still there. The world was a completely different world. Gandhiji was still working in South Africa. That was the time when this department was started, just to put things in perspective. In that whole history of 113 years of the department, I'm sure certain milestones stand. 1955-56 would be one in which this block came about. I think 2024 has a legitimate right to be termed as a milestone year for this department, where a completely new block has been sanctioned with the government of more than 300 crores, which
और अब हम सम्मानित करना चाहते हैं हमारे स्टाफ के सभी कर्मचारियों, स्टाफ नर्सेस को, जिन्होंने पेशेंट के प्रति, वार्ड के प्रति अपनी पूरी कर्तव्य निष्ठा के साथ काम किया और ये सुअवसर हमको दिया कि हम उनको सम्मानित कर सकें। तो स्टाफ नर्स श्री योगेश बंसल, श्रीमती ममता त्यागी, श्रीमती ममता त्यागी, श्रीमती कंचन लता, श्रीमती विभा पैट्रिक, श्रीमती विभा पैट्रिक, श्रीमती नतालिया एंथनी, श्रीमती यशोदा यादव, यशोदा यादव, श्रीमती सविता देवी, श्री प्रदीप शर्मा, सविता देवी, प्रदीप शर्मा, एंड सुश्री सविता गौतम। ये सब हमारे स्टाफ नर्सिंग ऑफिसर्स हैं जो विभिन्न ओटी और वार्ड में कार्यरत हैं। कंग्रेचुलेशंस। अब मैं निमंत्रित करती हूँ ओटी टेक्नीशियन श्री केपी यादव और मिस्टर रोशन पांडे। केपी यादव, रोशन पांडे, ऑफिस स्टाफ श्रीमती ज्योत्सना श्रीवास्तव और लाइब्रेरी श्री संजीव श्रीवास्तव। ज्योत्सना श्रीवास्तव, श्री संजीव श्रीवास्तव, अब मैं निमंत्रित करती हूँ सिक अटेंडेंट्स श्री एनुल हक। हमारे सिक अटेंडेंट्स और सफाई कर्मचारी इन सबको हमारी तरफ से कैश अवार्ड भी है विभाग की तरफ से। तो सिक अटेंडेंट श्री एनुल हक, श्री आशीष कन्नौजिया, श्री सिरताज अहमद, श्री सुनील कुमार, श्री सुनील कुमार, श्रीमती अनीता मिश्रा, अनीता मिश्रा, श्रीमती अनीता मिश्रा, श्री विकास रावत, विकास रावत, और श्रीमती गुड्डी। सफाई कर्मचारी श्री हरिशंकर, कॉटन सेक्शन, श्री हरिशंकर, श्री सुशील कुमार, श्री सुशील कुमार, श्री मुबीन खान, श्री सुमित, श्रीमती सरोज। और विशेष प्रोत्साहन श्री रवि कुमार वर्मा, इलेक्ट्रॉनिक सेक्शन। श्री फरहान मोइन अहमद, IT सेल। and Shri Vinayak Srivastav, IT cell. Vinayak Srivastav, IT cell. सुमित, आप जाइए। सुमित हमारे सफाई कर्मचारी हैं जिनका नाम शायद छूट गया था। Thank you. Thank you. May I request the dignitaries to please be seated for a group photograph with the award recipients. Thank you all. The award recipients can go back to their seats.
We would now like to felicitate our respected dignitaries. I request Professor Sonia Nityanand Ma'am, our respected Vice Chancellor, and our respected Head of the Department, Professor Abhinav Arun Sonkar Sir, to kindly felicitate our esteemed Chief Guest, Shri Parthasarthi Sen Sharma Sir. I would now like to request our respected Head of the Department, Professor Abhinav Arun Sonkar Sir, and Professor H.S. Pava Sir, to kindly felicitate our respected Vice Chancellor, Professor Sonia Nityanand Ma'am. I would now like to request Professor K.K. Singh Sir and Professor Suresh Kumar Sir to kindly felicitate our respected Pro Vice Chancellor, Professor Abhijit Kaur Ma'am. I would now like to request Professor Surendra Kumar Sir and Professor Avnish Kumar Sir to kindly felicitate our respected CMS, Professor B.K. Ojha Sir. Respected dignitaries, kindly be seated. Thank you, respected dignitaries. It is now my honor to invite the driving force behind this grand celebration, our esteemed organizing secretary, the very dynamic Dr. Parijat Suryavanshi sir, to deliver the vote of thanks.
A very good afternoon to all. It is a remarkable day for the Department of Surgery, King George Medical University, and it is my privilege to present vote of thanks speech and put all my gratitude into words for those who worked very hard to make this occasion memorable. Let me first of all start by giving glory to Almighty God for making today's occasion a resounding success. First and foremost, I thank our chief guest, Mr. Parth Satish Sharma, Principal Secretary, Medical Education and Health, Government of Uttar Pradesh, who despite his busy schedule has found time to honor this function with his gracious presence and inspirational thoughts. We are extremely grateful to you, sir, for your presence today. May I take this opportunity to express my sincere thanks to our Honorable Vice Chancellor, Ma'am, Professor Sonia Nityanan, for being a rock of support for Surgery Department. Ma'am, we are truly overwhelmed with your presence and blessings that has made this event a success. My thanks to Professor Abhijit Kaur, ma'am, Honorable Pro Vice Chancellor, for her valuable contribution, guidance, and encouragement in all efforts. Thank you, ma'am. I deem it a great honor and privilege to thank Professor B.K. Oja, sir, Chief Medical Superintendent of King George Medical University, for accepting our invitation and gracing the occasion with his presence. Thank you, sir. As I stand on this platform, I would especially like to thank our head of department, Professor Abhinav Arun Sonkar, sir, for giving me the opportunity to organize this event under his leadership. His continuous support and inspiration had made this event a grand success. I would like to extend my special thanks to Professor K.K. Singh, sir, and Professor H.S. Pava, sir, for their humble suggestions for the better outcome of this program. My heartfelt thanks to all respected senior faculty members and dear colleagues of the department for helping and guiding me in every possible way. I'm also thankful to all the distinguished invitees and dignitaries present here for accepting our invitation. Now, my special thanks to one dominant force behind this function, and that is Dr. Akshay Anand. Dr. Akshay, he made an immense contribution in organization of this event, but as you all know, helping others is his humble nature. He has immensely contributed to this department with his administrative skill, and it is a delight to watch him balancing his clinical teaching research duties along with immense administrative responsibilities. Thank you, Dr. Akshay. A special thanks to another faculty of surgery department, Dr. Nijamuddin Ansari, a humble, soft-spoken faculty who have played an important role as co-organizing secretary for this program. Thank you. I must not forget to thank all the postgraduate students of surgery department who contributed in organizing this event until the last days of the week. Thank you. मैं सर्जरी विभाग के सभी नर्सिंग स्टाफ और कर्मचारियों का भी आभारी हूं, जिन्होंने इस आयोजन को सफल बनाने के लिए कड़ी मेहनत की है. मैं कैटरिंग टीम, डेकोरेटिंग टीम, सपोर्टिंग स्टाफ का भी विशेष आभारी हूं. I thank from the bottom of my heart to all the print and electronic media for covering the event. I am thankful to all those whose names I might have missed, but who have worked behind the screen and supported me throughout. I once again thank you everyone for making this program successful. Thank you.
Thank you, sir. I request everybody to kindly rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय
I would now like to invite the residents and the staff for a quick group photograph session. I would like to request our respected Vice Chancellor, Professor Sonia Nityanand ma'am, and our respected CMS and Pro Vice Chancellors to kindly be seated for the group photographs.
I request all the residents to please come hurriedly on the stage so that we can have a group photograph. The faculty members of surgery, please come on the stage for a photograph.
All faculty and residents to kindly come on the stage for a group photograph session.
जल्दी करो ना फ्रंट में बैठ जाओ बेटा आ जाओ जल्दी से बैठो बेटा फ्रंट में बैठ जाओ आ जाओ
I request everyone to proceed for lunch. Thank you.